think one of the last workshops that we had was on quantitative research designs, but they focus mostly on the descriptive studies and correlational studies. So what we're going to do today is focus on quantitative research designs, but more of the interventional designs, so specifically experimental and non-experimental or quasi-experimental study designs. Okay. Okay, the objectives for today's workshop is basically to describe 3 characteristics of an experimental study, explain the differences between experimental and quasi-experimental research designs, discuss the major strengths and weaknesses of each study design, and discuss 2 components of how to control for bias in each of these specific designs. Okay, so really the research design is your blueprint. It's really, the action plan for what we're going to be doing in our research project. This is where we can identify techniques and procedures. Our plan has to reduce research bias. That's really the most important thing that we have to think about in terms of interventional or experimental studies, is really to reduce the bias. We have to control for extraneous variables within that design, and we also have to control for other sources of variance, which we'll talk about. In this type of research design, it's one of the designs that really looks at effects, cause and effect, and so we'll talk a little bit about that. It produces credible, high-quality research findings. It has to be clear and detailed, understanding study aims and purposes. We have to discuss how the research was conducted, evaluate the research process, and more importantly, our study design has to be reproducible. So that's how we have to think about the design, is that we have to make it clear, we have to have an action plan, and that's why one of the handouts that I gave you and I'll talk about is looking at or creating a study flow chart so that we know exactly what we're doing in terms of the research. Okay, so in terms of research design, there's a couple of different approaches. One of the workshops, I believe, Dr. Tyson spoke about qualitative research design, and really that's more about discovery, right? It's more subjective, it's a different type of methodology. Some of those designs or ways that we can do qualitative research is focus groups or interviews, things like that. Again, it was already discussed in a previous workshop, as was the quantitative descriptive study designs, the correlational and descriptive or non-experimental. So today we're going to focus on the quantitative, the experimental and quasi-experimental study design. Okay, in terms of the terminology, it can be confusing when we read certain things, because if we look at social science, we talk about it in terms of experimental or quasi-experimental, right? But when we read medical research, they might talk about it as randomized controlled trials, RCTs, randomized clinical trials, controlled trials. So, but they're one and the same. It's just the way they're referring to the specific design. Okay, there are certain quantitative research design interventions. In experimental research design, there has to be an intervention, right? So we're giving some type of treatment, some kind of medication to the patient. And some of those design options, if we have an intervention, is what we're going to be talking about, the RCTs and the quasi-experimental. Again, I mentioned earlier that we have to control for confounding variables so that we can really try to see if we can explain a cause and effect between the independent variable and the dependent variable. Okay, and we have to discuss how we're going to control those variables or how they are controlled within our design. And so one of the ways that we can do that is by matching samples. So in your intervention and your control group, you might want to match your samples. Do people know what I mean by matching?
The age and the sex and the.
Demographics are close. The demographic, the socio-demographics are very close.
So you control that.
Yes, you can, exactly.
Let's try.
And so the reason why we want to control all of these things is so that it's tight, right? So that it's very, I guess, standardized, if you will, okay? Another thing that we do in interventional research design is we do blinding. Does anybody know what blinding means?
Where you don't know which group gets intervention or which subjects get intervention.
Right, so if you're one of the investigators, you don't know where people were assigned, whether they were in the intervention group or the treatment group, right? So again, this is information so that we can control bias because each investigator has their own set of biases, right? So if you know that somebody's in an intervention group, you may treat that person differently if they're in the intervention group versus the control group. Does that make sense? So some of those things have to be part of your overall design.
What is the difference between single blind and double blind?
Okay, single blinded is like you are one person that that are blinded to one group, right? So, and then double blind is both groups.
Okay. So I would not know which group I was dealing with?
Right, so if you were a provider, you may know only who's in the treatment group because if something happens to them, then you have to treat them, right? In a double blind, you don't know
Which one
they're at. Okay. So we're going to talk first about quasi-experimental versus experimental research. Okay. Quasi-experimental research, what does that mean?
It's not as tight.
Right. It's experimental, so it uses the same type of design where you could have a control group and an intervention group, and you have an intervention, and you're looking at the causal relationships between each of those groups, right, and the effects on one variable over the other. But what is lacking in a quasi-experimental group? Well, we have to do that in all of the interventional studies, but the thing that's lacking in quasi-experimental is randomization. So that's really the main difference between true experiment versus quasi-experimental. And quasi, as you know, is like false. So it's false experiment versus true experiment, okay? And again, the design is really involving implementing a treatment and examining the effects of that treatment to your dependent variable or your outcome variable, okay? However, it can lack a certain level of control. So like Diane said, it's not as tight, right? So there may be certain biases within the manipulation of the treatment. There might be biases within the setting. There may be biases between with subject selection, you know. So again, not as tight, not randomized, but still an experiment, okay? Okay. So in contrast, the experimental research is an objective, systematic, highly controlled investigation for the purpose of predicting and controlling phenomenon in nursing practice, okay? So very tight control. We're going to establish causality between the independent and the dependent variables, and it's very highly controlled, okay? It's considered the most powerful quantitative method due to the rigorous control. But in nursing, we often don't do true experimental research. Why?
Yeah. Ethical reasons sometimes, because it's, you don't want to withhold treatment
Right.
that people need.
Right.
Well, just do people, it's hard to do people.
Right, when we're looking at human behavior, it's very hard to be very tight, right? So when do we often see true experiments?
I would say bench.
Labs, right.
There was a great article on NPR this week about how unrigorous bench mice are, because the top of the shells are different than the bottom of the shells. And we shouldn't be talking about rigorous experiment with animals even, because they're not the same. It was really interesting.
Not the same as humans too.
Well,
right?
yeah,
but not, yeah.
they're not test tube things. They're not, every little mouse is different.
Right, right. So, I mean, there's always different types of biases with any type of research, right? Even basic science research. So, but I think as researchers, we strive to do the true experiments, right? Other reasons, somebody mentioned ethics, maybe feasibility, right? You know, so it may not be as feasible to randomize due to things like funding, for example. You know, to do a true randomized study, I mean, it costs a lot of money and it takes a lot of time to do true randomization. Did you have a question, Ryan? So, okay, so this is just kind of a schematic of what a quasi-experimental study design would look like. So this is a typical quasi-experimental. Everybody knows about this kind of design. It's a pre-test, post-test. And I think oftentimes nursing researchers do this type of design where we have a study population, we do pre-testing, some type of measurement of whatever. So in my case, if I you know, discuss my, let's say, my new study on hypertension in Filipino Americans. So that's my population, right? So we do a lot of biometric measurements. We do a lot of measures looking at self-care knowledge, high blood pressure knowledge, self-efficacy, things like that. And then we do an educational program, which is our intervention, our treatment. And then we measure their biometrics again and do all of the questionnaires again. So that's a pretty straightforward study design, right? Okay, here's another type of study design for you to think about. Also quasi-experimental, also uses an intervention group. We see, again, non-random assignment to groups, but this time we don't do a pre-test on both groups, we just do post-tests. So we'll deliver an intervention to the intervention group and nothing to the control group, and we're going to see what the effects are of our intervention to the outcome variable. And so we just do a post-test. So that's another type of design that people can do that's pretty feasible. Okay, what are some of the advantages to quasi-experimental design? Well, they're frequently used because they're more practical, they're more feasible. In the absence of a large sample, randomization and or availability of control groups are not always possible. So we kind of talked about that a little bit ago. It's more suitable for real-world clinical settings than true experimental designs. And it allows the researchers to evaluate the impact of quasi-independent variables under naturally occurring conditions. So if we're looking at patients in a clinical setting, we can do observations in that natural setting as opposed to a lab kind of setting where we can really control everything. But it can still establish some causal relationships even though we don't have the randomization. You have a question, Jane?
No, I'm getting there, but I'll wait.
Okay. Anybody, if anyone has any questions, please just speak up. Okay. So let's talk about experimental research design. Again, I said it's the most powerful type of design. It's the gold standard. So again, as researchers, we strive to do that type of true experiment because it's one of the only designs that can really test for cause and effect relationships. Okay? The main components, we talked about this a bit ago, is controlled manipulation of at least one treatment variable, which is the independent variable. everybody know what an independent variable is, right? So, okay. And then, so it's the treatment. Whatever the treatment is, we're going to look at the outcome of that treatment. The other component is that it has exposure of some of the subjects to the treatment and no exposure of the remaining subjects. So typically, you have an intervention group as well as a control group. So you most often have at least 2 groups, okay? And again, we said the main component of a true experiment is the random assignment or randomization to each of those groups. Okay, so like I said, the simplest design, and we can think about this in terms of our own research, is to include 2 variables and 2 groups, okay, of participants. So we have the independent variable and the dependent variable, and those are our 2 variables. The independent variable is the predictor variable, whereas the dependent variable is our outcome, okay? So we have to think about it like that. Then the researchers can manipulate and control the independent variable to study its effect on the dependent variable. Okay, does that make sense? Okay. Then we have the 2 groups of participants. So they're going to either be assigned to a control group, no treatment, or usual care. Okay, so we remember, if we're going to do a control group, our control group can have standard care or usual care, or no care, or no treatment, right? And then the experimental group obviously gets the treatment or intervention. Okay, so that's, again, the basic, one of the simplest experimental designs. This is just a figure showing that. So again, control group, intervention, no intervention, and then post test. Okay. So in our study, I provided you with a handout, and again, this is all on Sakai. So if people would like to get additional copies. This is a schematic of our study design that we did in our randomized controlled trial. So this particular project, what we did is it was a multi-site randomized controlled study. We had 5 sites all over the country, east and west. We recruited over 660 patients to that study. And what we did is well, let me tell you a little bit about the study. So the study was looking at the intervention of education. It was a low literacy heart failure educational program, okay? And what we did was we identified the participants. We presented the study opportunity to each of the patients at each of the sites. If they consented, everybody got a baseline education. Why did we do that? We did that because as our team discussed it, we thought that there was too much variation in the knowledge, at baseline knowledge of each of the participants. And we wanted everybody to be on the same playing field. So what we did is we provided every single person with a standard educational program at baseline. Okay, so everybody, control and intervention group got that. Okay? Then after that, we randomized. And how did we randomize them? Basically, one of the easiest ways to randomize, and there's lots of ways to randomize, but what we did is we picked an envelope, which basically decided or allocated the patient. So if Jane came to me and said she wanted to participate, and she went through these steps and consented, then we would just pull it, and then she would either be in the control or intervention group. And so it's all mixed, so we had no idea who was going to go where, but that's how we did it. Other ways to randomize are basically doing numbers or, random assignments by, what other ways can we think of?
By a computer
applications, different things. Just so that we don't know where you're going to end up, everyone has a 50-50 chance of getting into the intervention group or the control group.
Can you give us an example of the baseline education you did with the heart failure folks?
Right, so we just basically gave them the brochure. I mean, we had a manual that we gave to everybody. So the people in the control group, that's all they were left with. Okay, so in a way it was considered standard care because we felt ethically heart failure patients at minimum should have some type of education if they have a diagnosis of heart failure, right? But given that we had multiple sites, we couldn't guarantee that each person had any education at all. So it was unfair for us to say that, oh, if you're in the control group and you have diagnosis of heart failure, you're not going to get anything. Do you know what I mean? So we did have a low literacy manual that we presented and we educated the patients with. The person who delivered the education was a health educator. So, but once they were randomized into the intervention group, they fell into the teach to goal intervention, which then, based on the education, they got several other ongoing education and calls, follow-up calls. So that was really the main intervention, is taking this baseline education, but also providing strategies for using the teach to goal method. So we called them, we identified what their goals were for the week, we worked with them for each goal. For example, if they just wanted to weigh themselves for that week, that was what we focused on. So then once they met that goal and mastered that goal, then they went on to the next goal. So that was really the intervention.
And I think you can do it any way you want to, but did you measure whether the not intervention, the other control, lost that. Control group, did they have to read the book? I mean, do you know whether they did anything or not? I mean,
everybody got it with a health educator.
Okay, so they all got a lingo, read this book.
So here was our data collection, so maybe I should talk about that. So everybody, once they consented, and even before they got baseline,
Okay.
we collected data.
Okay, so you knew whether they could read English or what.
And then we did the TOEFL, which is a literacy screening test, right? So it decided whether they were low literacy, adequate, or high literacy. Okay? And then that was important because in analysis, we stratified them based on literacy to see if our low literacy educational manual was effective, right? And so, and then we followed them at 1 month, 6 months, and 12 months. So
both groups?
Both groups, yeah. So whatever you do to the intervention group, you have to do with the control group, right? So you have to measure them all at the same time, the same way.
Okay.
The only difference is that our control group didn't have this.
They were kind of on their own.
Once they got the baseline, they were done, right? And then we would call them back to do the follow-up.
And you use the same questionnaire
Absolutely.
at 1 month, 6 months, and 12 months.
Yeah,
And
you have
the
to have
number of both groups, like the random, like for the control and the intervention, you don't have any control to make sure both groups have the same number of participants.
No, we did. We tried to match all the sites. We continually did evaluation to make sure that we didn't have one site that had more than another site. We really tried to control how many people came from each site.
But like for
Is that
the
what
same site, like for the two groups, do you make sure like for the intervention group I have 30 and for the control I also have 30?
Yeah, so you have to try to have similar numbers for both groups.
So how do you do that? Like because from the randomization, they randomly pick up an envelope. So maybe like how do you make sure both groups have equal number of participants?
Well, you just have to keep track of it.
And you have to wait until you've enrolled this many participants to begin.
And in each site, you have to monitor who's in the control and who's in the intervention group. Because again, you have to try to have similar sample sizes for each site.
So you needed 60, you need 30 in each one.
So what are you
So
asking?
like my question, like for example, for 5 of us, like if like just accidentally, all of us, we chose the intervention group. And
Mhm.
then the control group is gonna be 0. So how could you make sure like equal number for both groups?
Oh, I see. Well, again, I think it's just really monitoring that. I mean, if you see that everybody's going, I mean, it should be mixed, because most of the time if you have intervention or control, it's gonna be one or the other, right? And so you should end up having the same numbers in each group. If you have 30 envelopes, you're gonna end up with 15 or 15.
So half of the envelopes are labeled
Right,
control, half
right.
are labeled, experimental, and then maybe the first 5 pick control, but then the
But
last
that's
5
okay,
pick
because
experimental.
eventually, yeah, you're gonna end up having at the very end, like Jane said, a group that's gonna be similar sizes in both intervention
How
and
you label.
non-intervention. Does that answer your question? Sorry.
So I have a question, because I did this very study in my master's program, but it was with a different population, and where they dinged me was the intervention. So there was an experimental and a control group, and I did weekly interventions with my experimental children, alcoholic parents. But for the other one, everybody had a baseline, but for the other one, they were out on their own, and nobody contacted them. So what they said to me, until we had to contact them, okay? And what they said to me is, well, how do you know? So I want you to answer my question, because I couldn't at that level, and I still can't.
Let's see if I can.
But they said, but how do you know that it wasn't just somebody caring about them enough to call? Maybe it wasn't your very intervention of talking about a goal. Maybe they just needed socialization, and you could have talked to them about anything.
It's true.
So do you think it would be more true experiment if we would take that non-experimental or control group and just say, hi, how you doing? I mean, just every week.
Well, the problem is then you are doing some type of intervention.
Yeah, it's true.
So really you can't, because, and I agree with you, and it is a limitation of the study,
Yeah.
because you're right. And we had to address it ourselves, because our health educators were the ones who did the education. They were also the ones who called every single time, okay? So our rationale for doing that was in the Latino population, which was what we were really trying to focus on, is that trusting relationships really important in order to be successful in the intervention. And if we had a random stranger calling them and checking on them, they may not be as, open to telling us or trying to be effective in their intervention. So, we just posed it as a limitation. Everybody knows it's a limitation. And there's no way to get around it, because we're never going to know for sure whether it was just the mere phone call, or was it the relationship, or was it really the intervention. But whatever it was, this was effective, okay? Yeah, whatever it was. I mean, we would say that. So, okay, so that's kind of basic in how I'm saying it. So other analyses can look to see if there were other mediating and moderating variables or confounding variables that introduce bias, because what we're talking about here is bias, right? That introduce bias within this intervention group, okay? So remember, we have to control bias. So how do we do that? So, as a researcher, you have to try to control as much of that as possible. But then another analysis that we did after we looked at the main outcome variables was to look at structural equation modeling, to look at whether the mediating and moderating variables did affect the intervention. And there's a paper on that if you guys are interested in that too.
One of the things we did a similar study, and we did colorectal cancer education intervention for Korean Americans in churches. And for the control group, because we didn't want them to feel left out, we did a basic nutrition education. Not at all related to colorectal cancer and stool testing and everything else. Then we evaluated how many followed through with returning their colorectal. Yeah, and then later we did a crossover design. And we gave the intervention group the nutrition education, the control group, because our ultimate goal is to increase colorectal cancer screening. So that was one way we were able to still address the fact that the control group might have felt left out. But we gave them something, it wasn't the intervention.
So that's a good point, Coy, thank you. Yeah, so you can do other types of designs that can look at the other group too, like the crossover design. So what we could have done is once we completed the year study, we could have asked these guys to then participate in this to see if it was effective, right? But let me talk about another design, which is what we're kind of talking about now, which is pre-test, post-test with multiple groups. I think we kind of talked about that. But this is another design here where you might have 4 groups, but you're doing something different with each of these groups, and this will even, further control any type of bias within each of the groups. So let's just say group 1 got the pre-test, they got the treatment, and then they do the post-test. Group 2 got the pre-test, no treatment, and then a post-test. Group 3 had no pre-test, but they got the treatment and then the post-test. And these guys only did the post-test. So then you can see with each group if there were any variations within the effect to the outcome variable that you have based on how you've assigned them. So again, by having multiple groups or by doing a crossover design like I was saying, you try to control whatever variances there are within your treatment group. Any questions
It
about
just
that?
increases the complexity of time, of money,
Absolutely.
research personnel, of everything.
Absolutely, but if you're really trying to figure out, is your intervention really
What makes the difference?
worth it, worth the cost, worth the money, you have to test it. That's the only way you're gonna figure it out, right? So again, we've kind of talked about this already, so important things to consider really is to control the study, to control that there are variances in experimental design and the bias. And this is, again, kind of repetitive because we kind of talked about it in that example, but control involves the imposing of rules by the researcher to decrease the possibility of error. So we talked about that, and that's why we have multiple groups. Hopefully we can see that we've reduced any type of error. And if you can see here, this is just kind of a table where if you look at descriptive and correlational studies, they're very uncontrolled. You don't know, where they're at. It's usually occurring in a natural setting. So it's very difficult to control. And that's why when we focus on quasi-experimental and experimental, they're a little bit more controlled. And as we said in the experimental group, laboratory or research unit is very controlled. So there's this one study that I wasn't involved with, but I know the principal investigator, and he was looking at hookah smoking. So one of my PhD students at UCLA was really interested in hookah smoking and trying to increase awareness of adolescents and hookah smoking. Because as you know, it's really, it's
Healing
the pipe with the water, and so a lot of the adolescents think that it doesn't have nicotine, but it actually delivers like 100 times more nicotine than cigarettes. So it's a very cultural type of thing, and she was no research. She was really interested in this because the prevalence for lung cancer is really high. And oftentimes the kids start smoking hookah at maybe 9, 10, 11 years old. And it's part of, like I said, the culture. So they do it at family parties and everything. So anyway, so we got involved with Cedars-Sinai, and one of the PIs there, Dr. Ron Victor, he's done a lot of research on high blood pressure, cardiovascular disease. He actually had a smoking lab. So he recruited people. So how ethical is that? I don't know. But he got a lot of money to create the smoking lab so he can create a laboratory where he can control how much smoking the people got. They were able to measure their heart rate, their respiratory rate, all of their, biometrics, everything within a laboratory setting while they were smoking. So again, really tightly controlled, but that's the only way that you could do it, because if he just got people smoking in natural settings, they could be doing it anywhere. He couldn't control the dose, and that's one thing we haven't really talked about is dosing of the intervention, right? So, it's kind of interesting how far people go to tighten or to control their study. Okay? Okay, so we talked about variance and confounding variables. Systematic variance is variance due to the effect of the independent variable on the dependent variable. So things that just occur that affects the independent variable that can affect the dependent variable. Other things are extraneous variance or nuisance variables are the other confounding variables, right? Controlled by randomization. So what other kinds of extraneous variables might one think of when, or try to control when they're doing an experimental design?
Noise, distraction, anything which keeps the focus from your intervention that's being given.
Mm-hmm. Anything else?
Well, I'm thinking in my case, if somebody overhears a intervention happening,
Mm-hmm.
they might be biased onto their answers.
Right? Because they heard somebody else talking about it.
Well, you don't know what the people are coming with from home. I mean, they could be coming from a really bad day, a really good day. Those are all stuff you can't control.
Right.
But also in the smoking lab, you don't know for certain that they're not using some other kind of drug on top of the tobacco. I mean, you ask about it, but it could be
Right, but if they're testing the person right then
in
and
the
there,
lab.
right, you
Control that.
can control that they're not doing any other substance
Right
while
now.
they're smoking in the lab. But that's what I'm saying, if you were outside and you were monitoring them on the outside, it would be very hard to control for extraneous variables because, like you said, you don't know if they're smoking something else or how much they're smoking, secondhand smoke, how much they're smoking, So there's a lot of things that you can control within that lab that you might not normally be able to control in a natural setting. Other extraneous or, nuisance variables might be things like, let's see,
Did they sleep well last night? Did they not sleep at all last night?
yeah, or it's something that's happening in their life or,
So if there was a natural tragedy that was going to affect their biometrics possibly, would that be a nuisance variance or would that be error variability?
Well, if it was a natural tragedy, I would say it could be more of an error variance, I think.
When the national terror of December 2014 happened in San Bernardino, and you had your testing scheduled that day, or you were giving your instruments, your surveys that day, then people might be much more fluctuating.
Yeah, so I think that would be more like an error variance because it's variability due to something random, right? You can't really control this, I think, as much as you can control some of these things. So the other variances that I can think of is, really controlling for age, for gender, for different assignments, things like that. Those are the more common things that you might want to control for. Contamination, like Lydia was saying, contamination of not only data collection, but contamination of the intervention. So if you had a group, an intervention group in one place, but they were talking to their friend who happened to be in the control group, then they're contaminating the control group and introducing bias to them, so then the results of the control group may be, different. So you need to try to control that a little bit. So one of the things that we've done too is having one control group in one site and then an intervention group in another site, quasi-experimental. We didn't randomize that, but it was one way to try to prevent one group from talking to the other group. So, okay, we have just a few more minutes. Okay, and then bias, we talked a lot about that already. So it's defined as a slant or deviation from the true or expected. And we just have to be aware of our own biases too. That's one thing as researchers. So really a bias is any component of a study that deviates or causes a deviation from the true measurement of the study. So we talked a lot about that already. And so it's important to focus on critiquing a study to identify these possible sources of bias. And I know in class, we talk a lot about this. How do we reduce the bias so that our study is as clean as possible? So here are some examples of bias. So it could be, like I said, attitudes or motivation of the researcher. It could be the environment. It could be how we selected the individuals, the groups that were formed. Are they very homogeneous or heterogeneous? So these things are tools. We talk a lot about tools in our class just because it's really important to be able to identify which tool best measures the concept or phenomenon that you're going to measure, right? Because that's really important. So if you don't find a really good tool, you're introducing a bias into your study already. Okay? Data collection process, data and statistics. Okay, and we talked about controlling for bias. We talked about it in terms of randomizing the sample and in terms of blinding. Okay, so let's talk a little bit more about randomized clinical trials. Again, not seen very much in nursing because it uses large numbers to test the effects, and subjects are drawn from a reference population using clearly defined criteria. So you have to really create a very stringent inclusion and exclusion criteria, so your sample is pretty much the same. Okay. And the validity of randomized control trial really depends on Nelson, and randomization ensures that what we're measuring is balanced out between the two groups, okay? And if a factor other than the treatment itself could possibly influence an outcome measure in your study, then the randomization generally fixes that. So that's why we really need to have randomization. Okay. Any questions about randomized controlled trials, experimental and quasi-experimental? Because the next couple of things, I'm just going to touch on that, but these are just parts of clinical trials, is the intention to treat analysis. So basically, it's a method of analysis for randomized trials in which all the patients who are randomly assigned to one of the treatments are analyzed together, regardless of whether they completed or not. Okay, so oftentimes if we have a study, we usually have dropouts or attrition, right? So in this case, if we have an intention to treat analysis design, then we're going to look at everybody and look at the data so that we can see why did they drop out, what happened to them, all of that. Because if we drop them and we don't look at their data, we may be missing a lot within our analysis.
But if they drop out, how are you going to know why they did or what happened to them? I mean, you're making,
You just,
All
you
still.
measure up until the time they drop down. Or you could do a follow-up and see. But in any case, oftentimes if a person drops out, you throw out that data, you throw out that file, right? And you don't look at that. But intention to treat analysis, you have the intention to look at that, to see if there's any variance that caused them to drop out, or what was going on with that particular patient. Okay, it avoids the problems created by omitting dropouts and non-compliant patients, which can negate randomization, okay, and introduce some other biases. So again, it's just a different type of analysis that you can use to reduce bias within randomized trials. So everything, as you can see, can be fixed by looking at different analyses. So as we said in class too, in my research class, that's why it's really important to think about what types of analysis you can have, and it's important to look at the highest levels of measurement so you can have the greatest possibility of analysis. Okay? So when people want to do studies looking at dichotomous variables, yes, no, male, female, and that's it, you're really restricted to what statistical analysis you can do, and therefore you can only report on what you can analyze. Does that make sense? So the more sophisticated your design, the more, the higher level of measurement you choose, the higher, the greater, the more statistical analyses you can do and report on. So in our RCT, if we didn't have a very sophisticated design, we would never be able to do structural equation modeling with our project. Okay. So briefly, this is just a couple of other terms that I just want you to be familiar with. Again, it's another conversation, but number needed to treat and number needed to harm. Okay? So number needed to treat is the number of patients who need to be treated in order to prevent one additional bad outcome. So the number of patients that need to be treated for one benefit compared with a control in a clinical trial. So how many patients do we need to have one bad outcome? So that's number needed to treat, okay? And these are sometimes specific, like for vaccinations. The other term is the number needed to harm. And that's different in that it indicates how many patients need to be exposed to a risk factor over a period of time, excuse me, to cause harm in one patient that would not be otherwise harmed. So, does everybody understand now? So, how many people have to be exposed to one thing before somebody
And the one thing is what you're looking for? I mean, yeah.
So if you have like a chemotherapeutic drug,
Okay.
and you're giving it all to somebody, you want to analyze the data to see, can you give this chemo drug to 100 people before one person can be harmed? Or can you give it to 200 people?
And how do you find that out?
Well, you're looking at the outcomes of the data.
So you only have 50 in your randomized trial,
Right, if
and
you
none
only,
of them have a problem. You
right,
would
so
say
that's
zero?
why in a true randomized trial, you need really large samples
Okay.
to be able to do these kinds of analysis. So this is just another type of analysis, and it just goes to show the effectiveness of that drug. So
Okay.
for example, if you had 50 people and 25 people were harmed by that drug,
That's a lot.
you're not gonna say that it's a very good drug, right? But if you had 10,000 people and 2 people, right, so that's why they have those things on the inserts of the medications. It's your percentage of harm that can occur if you took them.
I didn't understand. Gotcha.
The drug. Okay? All right, so in summary, let's just look at advantages and disadvantages. We kind of talked about it. Advantages of experimental design, it's objective. It establishes cause and effect relationships. Disadvantages, it lacks objective data about human interactions. It can be artificial because we're not looking at qualitative data. Okay? The feasibility, and sometimes we talk about it, could be unethical. right, to do that. Okay, so in this workshop, we discussed the term design. We identified the characteristics of experimental and quasi-experimental design. We discussed control. We discussed variance. We discussed bias. We discussed randomized clinical and control trials, and then we touched on the terms of number needed to treat and number needed to harm. So, any questions about any of that? No?
This is on the Sakai for
It is.
nursing faculty.
It is, it's on Sakai. So what I handed out is this worksheet that I often give in my class for quantitative research. And it basically goes through the research process. And so if you're thinking about some type of interventional research design, it's helpful for you just to put your thoughts into this worksheet so that it kind of helps, it helps guide you in your design work. And I have found it very helpful too. So,
Thank you very much.
anything else?
Thank you.
Also in Sakai, like I said, if you didn't hear, I have a article regarding the RCT that we did in there, so if you want to read it and get more detail on that, please do.
What we can do with saving the recording.
Oh my God. I don't know how to do that. Should we just end it?
Mm-hmm.